Okay, so ladies and gentlemen, welcome to this amazing session today, which is the 360-degree holistic approach to MS and how to navigate modern migraine management. Assalamu alaikum, and I am so pleased and honored to be here in the presence of two esteemed speakers. I would like to thank our sponsors, Lundbeck, for putting up this very pleasant webinar, and also the IVPN NeuroPsychiatry Organizing Committee. My name is Dr. Ruqayya Mir. I am a consultant neurologist, and I work at Abu Dhabi Stem Cell Yas Clinic. Migraine is one of the treatment that most of the neurologists treat, and I'm here today as your moderator. I'm just going to briefly tell you about migraine. As you know, it's one of the most common, or should we say, the World Health Organization states that it is the second most prevalent chronic disease in the world. It is highly prevalent and highly burdensome. And I'm sure many of you don't share with your colleagues that you have a migraine because you might think that they look at you in a different way or may have this stigma attached to it. So without further ado, I would like to introduce my first speaker, who's going to tell us about the psychiatric approach, followed by Tawi, will tell us more about the modern management. However, I just want to say that if you might be aware that before, and I'm glad I'm not living in that era, they used to treat migraine by making holes in the skull or, putting hot iron or bloodletting. So we are lucky that we are in an era where we are now blessed with modern treatments. So my first speaker is Dr. Hamid Al-Haj. He is distinguished speaker, consultant psychiatrist who has got doctorate in psychiatry from Newcastle University, UK. And after completing his training, he has had extensive experience both as a consultant psychiatrist in the United Kingdom, as well as associate professor of psychiatry at the College of Medicine, University of Sharjah. And he holds a position of director research to the National Association of Psychiatric Intensive Care and Low Secure Units in the UK. He has many qualifications, and I would probably just start and give them to our distinguished speaker. So Hamid Al-Haj, please, the floor is yours.
Thank you very much indeed, Dr. Ruqayya, for the wonderful introduction, and thanks very much to IVPN and Lundbeck for the kind invite. So let me start by sharing my slides. Hopefully you can see my slides at the moment. Can you confirm that you can see the slides? Okay, so I'm going to talk about migraine comorbidities, and I would like to start by the question, what are the common migraine comorbidities? I'll talk about psychiatric comorbidities. I will briefly cover the physical comorbidities, and I have a case study that I would like to share with you, ending by a conclusion. So really, when we say comorbidity, we are talking about two existing medical conditions in the same person, of course, or more than two existing conditions. And it's important for us to understand the comorbidities in migraine, because some conditions can have similar symptoms. So the symptomatology may overlap, like epilepsy and migraine. They both can cause headache. So if someone has headache and two conditions, we need to be clear which is causing which. But also the treatment can sometimes overlap, or indeed can cause trouble when we are prescribing one medication for condition A, and the condition B may deteriorate, or the drug-drug interaction between the two conditions. We know that many migraine medications or antidepressants can lower the threshold for epilepsy. So knowing about the comorbidities is essential. How can we test for comorbidities? We can do population-based studies, we can do clinical studies, we can do case control studies, but really we have to be mindful of the design of the study so we understand any biases, whether it's selection bias or whether it's recall bias or publication bias. So looking into a large study that was done in the US, around 15,000 people with migraine and over 77,000 people without migraine, testing for the common conditions, we see that particularly insomnia, gastric ulcer and GI bleeding, depression, anxiety, angina, and circulation problems, these seem to be the most likely to be associated with migraine. Of course, all the conditions presented here, they have an odd ratio of higher than 1, suggesting that they do have a higher chance of comorbidity. So the burden of the disease is another major problem. And as you know, if you can look into the bar here, the green bar suggests or it delineates the chronic migraine. So someone who has 15 days or more per month of migraines, and the light brown bar is the episodic migraine, so 14 or less of days of migraine. And of course, we do expect more people in most of these studies to have episodic migraines because chronic migraine is more severe. But you will see the burden of the chronic migraine is very clear with things like allergies and hay fever. Nearly 60% for those who have chronic migraine have the burden of comorbidity. Similarly, we have, but with less severity, we have things like depression, sinusitis, anxiety, and chronic pain. So just to dig a little bit deeper into the prevalence of various comorbidities among people with migraine based on headache frequency, here we are, instead of just dividing them into 2 categories here, we're dividing into 4 categories. So 0 to 3 monthly headache days, 4 to 7, 8 to 14, and above 15. So 15 and above would be the chronic, but the other ones would be episodic. And there is, as you can see, the higher or the more severe migraine, the more likely that people have those comorbidities across the board, basically. So what about the psychiatric conditions? These are some of the most common comorbidities. Well, if we talk about depression, anxiety, bipolar, ADHD, they all are common comorbidities in migraine or in people who have migraine. Migraine is a neurological condition. And the question why people with migraine may have these psychiatric conditions is quite complex, because it's not one leading to the other. It's not as simple as, because I have headache, then I'm feeling depressed. It's bidirectional. It's caused both ways, and they have common autopathological determinants, particularly genetic, neurotransmitters, even the pathways within the brain, the circuitries, the affective circuitry, and that involves areas like the hippocampus, the amygdala, the anterior cingulate cortex, and the prefrontal cortex. So this emotional and memory-related neural circuitry is also involved both from a functional as well as a structural point of view of migraine. So let's talk about each psychiatric condition in a bit more detail. So depression is a condition where people feel low. They experience anhedonia, meaning they don't enjoy pleasurable activities. They have difficulty with their sleep. Either they don't sleep enough, insomnia, or they sleep too much, hypersomnia, but still they don't get refreshed by the sleep. So by the next day in the morning, they feel tired, they feel fatigued, they are unable to concentrate on activities they are supposed to do. People with depression, usually they don't have good appetite. So they either lose the appetite and lose weight, or sometimes they start to eat more, not because they enjoy the food, but what they call emotional eating, which can lead to increased weight. Now, people, because of the toll of the depression on their functionality, they start to question what's the point in living. They have low self-esteem and they might get suicidal thoughts. Physical symptoms in depression are common, including headaches. Now, as I mentioned earlier, the relationship is bidirectional. So people who have depression are more likely to develop migraine. People who have migraine are more likely to develop depression. The two conditions can coexist at the same time. Various studies, many studies have studied or looked into how depression and migraine coexist. And you can see that the odd ratio is anywhere between 2 and 4.5. So if you have one of the conditions, you're at least twice as likely to have the other condition, but it could be 4 times or more. Now, there is no specific treatment for depression in people who have migraine. What do we suggest? We suggest that treatment is essential. We do need to treat people who have depression, and that can improve the outcome for migraine. With bipolar is characterized by episodes of high mood, that's what we call mania. During a manic or a hypomanic episode, the patient would start to feel elevated and irritable because they have lots of plans, lots of thoughts, they speak rapidly, they have pressure of speech, flight of ideas, they want to do so many things, they don't sleep. Who needs to sleep? They are on the go. And when someone is trying to rationalize with them and telling them, can you please stop doing this? They become angry, agitated, irritable. So that's during the manic episode. But also people with bipolar have depressive episodes, which are very similar to what we explained in depression, where they have low mood, anhedonia, poor sleep, poor appetite, and suicidal thoughts. Now, depression is around 1% of the population in terms of how common it is. Bipolar is common around 1% of the population if we are talking about bipolar 1. But depression is far more common. Depression is around 1 in 6 people will experience a major depressive episode. Now, how is bipolar linked to migraines? We can see that the odd ratio is between 3 and 5. So really, having bipolar increases your risk of having migraines at least 3 times to 5 times, and the other way around. So you see people with bipolar, 30% of them, like 1/3 of people with bipolar have migraines, which is a significant number. And the reason why people have bipolar and migraine, it is also bidirectional. If you think about the pathways in the brain that I have mentioned earlier, they are relevant. The neurotransmitters, including dopamine and serotonin, they are also relevant. We need to be mindful for the treatment of bipolar because some antidepressants that may be used for migraine can trigger mania in people with bipolar. So we have to be very cautious if we are prescribing anything that would affect the mood. Now, in anxiety, people feel that they have worries all the time. They are always on edge. They think, what might happen in the future? What if things go wrong? So they feel more tense in their muscles. They might have palpitation or breathlessness. Anxiety affects your concentration, affects your ability to sleep, because if you're anxious, you're worrying about the future. In depression, it's mainly about ruminating about the past. But in anxiety, it's more about worrying what might happen in the future and what if things went wrong. Now, in panic disorder, it's also an anxiety disorder, but it's characterized by episodes of severe level of anxiety. So someone who has a panic attack will start to feel that they are about to die. They think they might having a heart attack because they get palpitation, because they get chest pain, dry mouth, they get very tense in their muscles, this churning sensation in the stomach, and so on. So what goes into the mind of someone who's having a panic attack? They are thinking, I am dying. They're thinking, I just need to get out of here. So there is no surprise that anxiety disorders are also associated with increased risk of migraine, and the odd ratio is anywhere between 2.5 and just below 4. So the likelihood that if you have migraine, you're more likely to have anxiety, and the same thing, if you have anxiety, you're more likely to have migraine. What's the cause of the increased risk? It's again combination of things. It is bidirectional. When you activate this fight or flight response, when you have the adrenergic response, but also when you have the HPA axis response as part of someone feeling under stress, then that can also trigger the pathways similar to anxiety, similar to migraine. And we know that 5-HT, which is serotonin, is implicated in both migraines and anxiety. How do we treat anxiety in people who have migraine? Well, we treat the anxiety the same way as we treat the anxiety in anyone else, by giving them behavioral therapies, cognitive behavioral therapies, as well as medications that would treat the anxiety. How about ADHD? So ADHD can be diagnosed in adults, but of course, they have to have it from the childhood. So we make the diagnosis of ADHD by looking into their neurodevelopmental history. So people with ADHD.
Dr. Hamid, you are breaking up.
Okay. Am I all right
Yeah, now you're. Yes, you are. Thank you.
So people with ADHD, they are hyperactive, on the go all the time. driven by a motor. That's how they are described. So cannot sit still. If they cannot run around, then they would be fidgeting while sitting, but also they're impulsive. So they say things without thinking. They might do things that they would later regret by maybe jumping from somewhere. If it's a child, jumping and realizing it was too high, so that might lead to a risky behavior. And there is the inattentive part of it, which is the child would be daydreaming, not paying attention to the teachers at school, not paying attention to parents, and moving from one topic to another and from one game to another, because they cannot sustain attention for long enough and they get bored easily. So ADHD is another condition that seems to be particularly important or implicated in people who have migraine with visual disturbances. The odd ratio is increased. It's around 1.76 to 2.81. So at least the risk is doubled if you have one of them to have the other. And we need to treat ADHD. We treat ADHD in a biopsychosocial approach, including working with children and parents and schools. And importantly, we have effective medications for ADHD that can increase the attention, reduce the impulsivity and the hyperactivity. Now, I think Dr. Ruqayya, when she was giving the introduction, mentioned the stigma, and the stigma is a major issue in migraine, but it's even worse for psychiatric conditions. People feel that they are being judged if they are constantly complaining of headaches. So they sometimes, I've met people with migraines who would not even say that they have migraine. They would just go and isolate themselves because, you know, it's another day where I have migraine and I have to complain to people and I have to either see the pity in their eyes or I just feel judged that, you know, this person is not strong enough, or this person is hypochondriac or something. These are all inappropriate ways to look into migraines. What's the situation for psychiatry? A lot of psychiatric conditions are seen as a sign of weakness, depression, anxiety. People ask the question to people with depression, you need, why can't you do it? Why can't you pull yourself together? When someone has anxiety, they start to question whether they are sane or not. Now, when someone is going through a panic attack and they're saying, I am going crazy, and then you go and tell them, stop worrying, there is nothing to worry about. What's the message that you're giving to someone who has a panic attack or anxiety? You're telling them that you are definitely going crazy because there is nothing to worry about. So I think education about this is key, because the fact that there is a lot of oxygen in the air, if you have asthma, you cannot be blamed for not being able to breathe. And the same thing, if you have depression, or if you have anxiety, if you have migraine, you should not be blamed for not being able to enjoy life when you are in pain, whether it's psychological or whether it is physical. So I'll briefly mention a couple of comorbidities with migraine, but of course, you know, chronic pain, fibromyalgia are more common, but also cardiovascular disease, inflammatory disease, respiratory conditions. Okay, so there are plenty of conditions we could talk about. I'll focus on some of them. So chronic pain seems to be particularly associated with migraines, and the odd ratio is, we're talking about 4 to 6. Really, it's not a small odd ratio. It is big, it's huge. And it depends on where the pain is, whether it's in your neck or shoulders or elbows, or particularly the upper back and the chest and abdomen. And these are the areas where people seem to have common pathways between being stressed, having chronic headaches, and having those pains because of the muscle tension. So fibromyalgia is another chronic long-term condition that is associated with psychiatric conditions indeed, and migraine. So many people who have fibromyalgia also have migraines and also have depression and anxiety. And you see that bidirectional pathway still applies here, because there are the genetic factors, there are the common neurotransmitters that are involved and implicated, there are the other stress-related factors that are implicated, and you see that particularly people with fibromyalgia, the chance of getting migraine is 22 to 40%, suggesting that it's much higher than the general population. It makes people enjoy life less. The quality of life is much less if you have fibromyalgia and depression and migraine compared to having one of them. The GI conditions, and here we're talking about multiple pathologies. We're talking about the irritable bowel syndrome as an example, where it's mainly functional, but we're also talking about the inflammatory bowel syndrome and celiac disease. Each one of them have different pathologies, but the striking issue is that basically these conditions all have high level of comorbidities with migraine, suggesting that there are a number of pathways, including the inflammatory pathway, including the gut microbiome function, where we know that the microbiome in the gut has links with the brain. And there is this bidirectional effect between the brain and the microbiome, which is implicated in why people with GI disorders may have migraines. So I would like to finish my talk by giving a case study. Of course, I have a picture here, but this is not my patient, okay? So just to help you visualize the patient, who was someone in her late 20s when she came to me first time. She is well educated with a master's degree. She was working initially as a researcher, but then she gave up her job and never applied for another job. The presenting complaint was that she had severe headaches, low mood, and anxiety. And she told me that for the last 12 months, she has been struggling with her mood. She has been feeling tired, not being able to sleep. She doesn't concentrate on anything, feels what's the point in living? She always felt tired and had low self-esteem. She was constantly feeling anxious. She was constantly complaining of physical symptoms of anxiety, including the tension, including the dizziness, palpitations. Wherever she goes, she would feel that she's anxious. She's at home, she's probably not as anxious, but she's still worried about life. And her situation was just getting worse. The headaches started several years ago, and she was diagnosed with migraine around 4 years ago. And she sought help. And initially, she received some treatments for migraines, but then, like after that, especially when she developed depression and she lost her job and she started to question the point in living anymore, she wasn't even interested in treating her migraines. So a little bit more about her background. She has a strong history of anxiety and depression in the family. And I happen to be also treating a number of her siblings, as well as one of her parents. So very strong family history of depression and anxiety. Now, she was born in the UK. She moved to the UAE because the family job, and settled here. Wasn't easy. She was bullied at school, like because of many things. Her accent, because um, the expectation, if you come from England, that you would speak like Queen language, but if you've lived, let's say, in Liverpool or in Newcastle, or I'm not saying where she's from to keep her confidentiality, but what I'm saying is that she had a strong local accent. So that was one of the reasons why she was bullied, but she was bullied for other reasons. So she managed to finish school, to study university, she worked as a researcher. There wasn't much in terms of, the social history, single, not in any relationship, not smoking, not drinking, not using any substances. Now, when she came to me first time, we started with a psychotherapeutic approach where we focused about how the negative thoughts, the feelings, and the emotions and the behaviors were all interlinked. We thought about her coping strategies, how she manages stress. And then I started her with an SSRI, which is usually a first-line treatment for people with depression. It works for anxiety as well. So we titrated the dose to the optimal level, the optimal dose. And she started to improve and her anxiety started to get better. And after I've seen her a few times, so the first time I got that in her history, she had migraines, but we stopped talking about the migraines for a few visits. And then like a few months later, she showed full remission of her anxiety and depressive symptoms. And then she told me, you know what? My migraines have started to improve, and I've decided now I have hope to go to see the neurologist, because as I said, she stopped going to the neurologist. She was using, whatever painkillers, naproxen, or any non-steroid anti-inflammatory drug when she was at her worst of depression, instead of going to the neurologist. But now, since she improved, she went to a neurologist, and her neurologist initiated a new management strategy for her migraines, which happened to be also effective. So I am very pleased, that her migraines are now far kind of more managed. She is no longer experiencing as many of these. So I would like to conclude by saying anxiety and mood disorders are prevalent in anyone, but particularly more prevalent in people who have migraines. And the reason why, it is quite complex, but there's shared pathways in terms of the psychopathology and in terms of the pathophysiology. And there are genetic factors, neurotransmitter factors, endocrinological factors. And let's not forget that stress is something that can increase any health condition, and migraine is one of them. So treating the psychiatric conditions is key. And I always speak with my neurology consultant colleagues, because we have lots of patients who we share the care for. And I think a multidisciplinary approach to conditions where comorbidities exist is the right way. And I would like to thank you very much for listening to my talk.
Wow, thank you so much, Dr. Hamid. That was so enlightening, and it was a pleasure. I think we can take some questions, and then we will welcome our next speaker. I've had a few questions here in the question box, and they're mainly focused on how can we manage this bidirectional relationship between migraines and psychiatric comorbidity. So is there something that you would propose from your perspective as a neuropsychiatrist? Is there any medication that the neurologist perhaps should know as well? You talked about escitalopram, SSI, but in some patients, we know that there is a lot of depression, anxiety, burden as well. We neurologists tend to go for the migraine treatment first, and we do feel that a lot of this improves. But I think for holistic care, what would you suggest, doctor?
Thank you. So that's a great question. And I think, psychiatrists and neurologists work on the brain. Both of us work on the brain. We look into the brain maybe from a different angle, but in the end, I think it's really important that we work together and personalize any treatment plan to tailor it to what would be most suitable to our patient. So in terms of this kind of bidirectional process, let's not forget the comorbidities. Okay, so I ask about migraine and other neurological conditions, and I do expect my colleagues, even if the patient isn't known to have depression, to at least ask a question about how is your mood, and maybe follow up with another question about whether you've ever felt life is not worth living, because these kind of two questions, could open up a key to why someone isn't improving to your treatment. I know that a lot of people improve, as you said, with now newer treatments for migraine. A lot of people do improve, but sometimes, they might improve in terms of the headaches, but they don't improve as much with the quality of life if we don't address the issues or the psychiatric comorbidities. So I think, referring not just for psychiatry, but also cognitive behavioral therapy. I know colleagues who work in neurology who would be referring directly to a cognitive behavioral therapist for conditions that have elements of, headaches or conditions, lots of other conditions that might, fibromyalgia, chronic fatigue, lots of conditions also need the attention of psychotherapy. So I think the evidence is best if we have a holistic approach, and if we work together, if we do a proper assessment, if we do screening. I usually do the GAD-7 and PHQ-9 for my patients. But of course, I'm a psychiatrist, but I encourage my colleagues to do those screening tools. And if someone is screening high on one of those tools, then you might be able to manage them, and you might be able to work with other colleagues to manage them.
Absolutely. I think this is such a wise thing to say, because we often just focus on medication, and we should be actually also monitoring them from more holistic view. We do anxiety scale or fatigue scale and look at their other comorbidities and then manage them. And unfortunately, sometimes the physicians don't have enough time. I'm sure you are the same, but this should be incorporated in all migraine care. I think the rest of the questions, they're mainly regarding this comorbidities and why does chronic headache, does it always mean chronic migraine when people suffer from chronic headache? Can we consider this as a chronic migraine? So I think chronic migraine definition, as you know, is very specific. And I think we have answered the question, and now I think we will go to the next speaker, and we can take the rest of the questions at the end of the session, if that's okay. So we thank you very much, Dr. Hamid Al-Haj, and now move on to our other distinguished speaker, Dr. Muhammad Al-Lahawi, who is a very good neurologist working currently at Sheikh Khalifa Medical City. He has got esteemed or distinctions in many things, and I would say that after graduating from University of Khartoum in Sudan, he has trained in UK and had several positions, including in North Cumbria and Birmingham, and also King Fahd. He is also, I think, honored by many of our colleagues, but as he loves education and he is an excellent teacher. So without further ado, I welcome my colleague, Muhammad Al-Lahawi. Please, platform is yours.
Can you see my slides?
So, yes, no, we don't see your slide yet, but we can hear you.
You don't see it now?
Not yet. So while
Now you can see it?
Dr. We see your screen, yes, but not the presentation. Yes, we can now. Just please put it like bigger for the PowerPoint, and then we are done. Thank you so much.
You can see it now?
Yeah, we can see it. Just put it on. Yeah, perfect. There we go. Bismillah.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Ruqayya. And thank you very much for London for this invitation. And thank you very much for the audience. It's difficult to give a talk after this very, very nice neuropsychiatric talk by Dr. Hamad Al-Haj. So I tried my best to catch on what he said, because what he took it from psychiatric point of view, and I'm taking the migraine from neurological point of view. This is my disclosure. Migraine is the Greek word, means half of the head, either the right side or left side, up, down, front or the back. Is the commonest disabling, as Dr. Rai mentioned, the commonest disabling neurological condition. We see it in clinical practice, and it, like MS, epilepsy, Parkinson's disease, and myasthenia gravis, requires pharmaceutical treatment. Required pharmaceutical treatment, as there is still no place for surgery yet. It might come in the future, but for the time being, the only way of treating migraine is by having pharmaceutical products, tablets. And every day, millions of tablets are ingested by people for migraine, and kilos of products are also used by patient. So there is two classification of migraine that may help us in the coming slides. That migraine with aura and migraine without aura. This is an old classification defined by the WHO many years ago, that we classified the migraine to migraine with aura and migraine without aura. But because after the introduction of new medications for migraine, a new classification emerged. We have episodic migraine, and this is divided in two types: low frequency episodic migraine with 6 attacks or less per month of headache, and the high frequency migraine between 8 to 14 attacks per month, and the chronic migraine which has more than 15 attacks per month. This is a new classification, especially for when you are assessing the response to the new medications for migraine. As Dr. Hamid mentioned, headache is just a part of what I call it mixed syndrome. Mixed syndrome is a syndrome with too many comorbidities like depression, insomnia, anxiety, fatigue, dizziness, isolation, feeling lonely, fibromyalgia, as Dr. Hamid mentioned, is the syndrome of too many symptoms. Most of them are neuropsychiatric symptoms, and headache or pain is just part of this syndrome. So when we are treating the patient's migraine, we should not concentrate only on pain. We have to consider all the other part of the, which were well explained in the previous talk. Migraine is not a black and white disease to diagnose or to classify. There are a lot of challenges in migraine treatment. One of them is many specialists or many specialties are involved in the treatment of headache and facial pain. This includes, as Dr. Hamid mentioned, the psychiatrist on the top, neurophthalmologist, neuropsychiatrist, neurosurgery, dentist, maxillofacial, ENT, and many specialists, even spinal, are included in treating patients with headache and facial pain. So that's one of the challenges. The other one is differential diagnosis wide. When you see a patient with headache, it could be there are too many differential diagnoses. So migraine is just one of them. That's why it makes the diagnosis of migraine is difficult. It's not easy. The second thing, sometimes it's difficult to differentiate between migraine and other types of headache, especially when the presentation is similar. I'm sure we miss so many patients with cluster headache as migraine, and we treat many patients with migraine as cluster headache, trigeminal neuralgia, affecting the ophthalmic division. We miss it with migraine, and we miss temporal with migraine. So because there is similarity in the type of pain and the site of pain of different conditions that mimic or that looks like or that look like migraine. The second thing is clinical examination. Blood tests and radiological tests are always normal in patients with migraine. We just rely on description. So we have to listen. And to my junior colleagues, to diagnose migraine right from the beginning, you have to listen to history. Because if you ask a patient to go to the couch, clinical examination will be normal in the majority of patients, or almost in all of them. And whatever test you send for is going to be normal. So far, there is no biomarkers to confirm the diagnosis. So only when we diagnose the migraine on clinical base, and sometimes on diagnostic therapeutic trials. We give them treatment of migraine, and if they respond, that means most likely it is migraine. There is no accurate pain measurement scale. This is another problem. We can't say to the patient, no, you don't have pain, or your pain is 1 out of 10, or 10 out of 10, or 7 out of 10, because there is no scale to confirm that this is painful condition, and the rate of pain, or the degree of pain, or the scale of pain is so and so. So it's one of the problems that facing us in managing patients with migraine. And the other thing is coexisting with other types of headache. Some patients have two types of headache. They may have daily chronic headache plus migraine, or they may have got a patient with trigeminal neuralgia and migraine, and I've seen a patient with daily chronic headache and migraine. So coexisting different types of migraine is one of the challenges that face a clinician in treating patients with migraine. if you say, why there is a long delay in migraine treatment? Because simply the pathophysiology was not known and still not fully known. We don't know the pathophysiology of migraine till now fully, so that the pharmacists can create or can manufacture medications to suit this pathophysiology. Recently, in the last decade or so, because we think that the CGRP playing a part of migraine, that's why we introduce the medications that antagonize the action of the anti-CGRP that improve the headache. So because we need to know the full pathophysiology of the condition so that we can create the treatment. Migraine treatment is either acute or abortive treatment for the acute attacks, or some people call it rescue treatment, and preventive or prophylactic treatment, and no treatment. No treatment, I mean, some patients we don't treat. If somebody gets one attack every 6 weeks or every 2 months or every 4 weeks, no need to treat. If somebody gets 2 attacks per month, again, no need to treat. So there are certain indication for preventive treatment and certain indication for acute treatment. It's a question, why we need preventive treatment for migraine, doc? Why we need to prevent the migraine from coming? And if you need, what are the indications of preventive treatment? My answer to this question is, we prevent the migraine, number one, to relieve the pain, to reduce the frequency of the attacks, to reduce the severity of the attacks and the duration, as well as to relieve the associated symptoms. As just been mentioned by Dr. Hamid, there are a lot of associated symptoms or comorbidities with the migraine. This is one of the reasons why we give preventive treatment. The second one, to avoid medication or analgesia overuse headache. Because if you don't prevent the attacks from coming, the patient will rely on the medication, analgesia or painkillers or pain relief tablets to improve the headache. And by time they develop another type of headache called analgesia overuse or medication overuse headache. We also have some side effects of most of the analgesia, especially recently, triptans are found to have sometimes serious side effects. The non-steroidal can affect the kidneys and stomach. So to avoid the side effects of the pain treatment and to avoid chronicity, because if the headache is becoming chronic, the patient will develop most of the comorbidities, especially the depression and the stress and the anxiety and the insomnia and the headache. The attacks of the headache will getting worse as well. So patients will be in vicious circle. So we need to break this circle. And we need to improve the quality of life, because no doubt migraine will affect the quality of life in a very negative way. What are the indications for preventive treatment? When we decide that this patient needs to have preventive treatment, it depends on the severity of pain, frequency, severity, and the duration of the attacks. This is one of the factors that we are indicated for preventive treatment. Vary from patient to patient. Some patients, yes, they have one attack per month, but we don't give them preventive treatment. Patients have one attack per month because of severe, unassociated with vomiting all the time, all day, so we might give him preventive treatment. Indications may change in same patient from time to time, and maybe more than one indication in some patients. So I like this table. These are 5 of my patients. Every one of them have got different indication for preventive treatment. Patient number 1, she's a young lady, 26-year-old female. She gets 1 or 2 attacks per month, duration up to 2 hours. Severity is 7 out of 10. Response to analgesia, yes. I do not give preventive treatment. So only 1 or 2 attacks per month, she can take whatever analgesia for that headache, and the response is good. So no indications. Patient 2, again, female, 5 to 6 attacks per month, and duration 2 to 4 hours, severity 7, and the response to analgesia is partial. These are real patients from my records. So the indication in this patient is frequency. So now she's getting into episodic migraine or low episodic migraine, so is there indication for preventive treatment? The third patient is 39 female, 1 attack per month, but she's in pain, or she's off sick, or she's at home for 5 to 7 days. Severity is 6, and no response to analgesia. So the indication is duration. So I'll give her preventive treatment to avoid this headache, so that or reduce the duration of the attack, so that you will have only few hours or 1 day that acceptable for her, rather than being 5 or 7 days. Patient number 4, for 6 years old male patient, 2 to 4 attacks per month, duration 24 hours, severity is 10 out of 10, no response to analgesia. The indication here is severity and duration. 2 indications. Severity is bad, and the duration is long as well. So we'll give him preventive treatment. And patient number 5, 34 years female, 4-7 attacks per month, 1 to 2 days duration, severity 7, and response to analgesia partial. So the indication here is the frequency. After 7, she's going to high episodic headache, more than 6 or nearly 8. So these are the indications for, to answer the question, what are the indications for preventive treatment? It varies from patient to patient, and you have to treat every patient different from the others. So don't say that frequency is 6 indication for treatment, because 6 might be, some patients might have 6 attacks, but they're mild. The pain is mild, no serious symptoms, a good response to analgesia. Don't jump to give them the preventive treatment. So you have to select your patient for the treatment. Preventive treatment divided into all preventive treatment. All preventive drugs are usually oral, and the new preventive drugs, which are oral injectable, or non-targeted. These are the old treatment. Our targeted treatment, this is the new medications, or we divide them to old oral, subcutaneous injection, infusion, and new oral. I think this is the best classification for the preventive treatment regarding the medication. We call it old oral medications, which we still use in some patients, and in some countries where the new medications are not available, or subcutaneous injection, infusion, or new oral preventive treatment. If you go through this round table, the treatment of migraine started many years ago with these oral medications. We use beta blockers, all types, anti-epileptic, mainly topiramate and lamotrigine and sodium valproate. Some people use gabapentin. Antidepressant, all types, but mainly amitriptyline or nortriptyline. And we use methyl sergide for a long time. I still remember the days where I started my training in late 1990s. We used methyl sergide. We still use it for some recent case of cluster headache. It's a very good drug, but the major side effects is retroperitoneal fibrosis, and I gather now we don't use it anymore. And then in 2009, 2010, we start to use Botox. So a long time using just oral. And then we have to use Botox injection. And then there's a gap between Botox injection and the new generation of anti-CGRP. We start to use erenumab, garkizumab, and eptizumab here. And then recently we have Kibans, which is oral. So this is a table or the history of the pathway of migraine preventive treatment. It starts from oral, coming to Botox, and then in subcutaneous injection, infusion, and back to oral. So this is a circle of the preventive treatment migraine. There was a long waiting time, or many years, between the oral drugs and the injection and infusion. I feel very sorry for people at that time, we treated with migraine for that time, or at that time, because there was no available treatment apart from the oral, which have sometimes have side effects and contraindications. So both patients and doctors are very pleased now and very satisfied with the recent pharmaceutical development in migraine prevention during the last 10 years or so. We are very pleased, very happy, because there are too many options. So prevention treatment moved from oral to Botox, to subcutaneous injection, and now to infusion. Or I put it that way, it moved from short-acting oral, Some drugs we give it once a day, like amitriptyline, sometimes twice a day, like topiramate, sometimes 3 times a day, like sodium valproate, and to long-acting subcutaneous for 1 month, erilumab and galcanezumab. And then now we have the very long-acting infusion, eftilizumab or Vyepti. It works the longest one for 3 months or for 5 days compared to the oral and subcutaneous injection. There's a question why we need to prevent migraine attacks. Why we need to prevent the attacks? And why not to treat them as they come or when they come? Okay. The burden of migraine in patient is bad enough to indicate preventive treatment. And people say any patient who develop more than 4 attacks per month, they are liable to have bad or negative effect on their life. 66 patients of having more than 4 attacks per month or 4 attacks per month are moderately or severely disabled. And 37% they have some level of anxiety, and 35% are depressed. They have depression. Imagine this is only having 4 attacks per month, but imagine somebody with more than 10 attacks or 12 attacks per month. So this ratio might double. So this is why we treat the migraine or prevent the migraine, because of the burden of the migraine on the quality of life. And this study from United States, 13,000 people were studied. 33 of them say migraine has affected their career. That's a large number. 33 out of 13, that nearly 4,000 of them, it affected their career. And in 23 of them were worried about being losing their job because of migraine. In another study called AMPP study, 18,000 were studies, half of them reported severe impairment of requiring bed rest. That means fatigability, tiredness, fibromyalgia, or mental illness. And 25% missed 1 day of work or school in 3 months before the study. So a quarter of these 18,000 missed, almost 4,000, they miss a day of school or work in the last 3 months before the study. So this is add to the burden of the migraine on the quality of life. And living with migraine can impact on family planning as well, choices and relationship. This again study, we call it ERO-LIGHT study. In this study, more than 9,000 responded to the questionnaire. 17% of them reported difficulty in their love life. 0.7 reported marital or separation or divorce because of the migraine. One of my patients said, if I did not receive my treatment, I will get divorced. So she responded well to the treatment. 1% reported having fewer no children. 1% out of the 9%, 9,000. So it has a negative impact on the family planning and the life of patients. Okay, patient burden increases with the headache frequency. The more frequent the headache you have, the more the negative effect of migraine on your health and on your life. As you mentioned, one of the reasons is to reduce the frequency, because if you reduce the frequency, you will burden. This diagram, the patient with the is less compared to people who get this, getting that ability from the again prevent reduce the of migraine will the freeze attacks, and hence the of the migraine on the early intervention, early started treatment is good treatment, long acting, rapid act, intensive symptoms, and in acute migraine, and it improves the response to acute treatment. what we noticed. Dr. Muhammad, are you with us? Hello? Yes, doctor, we can hear you very well. Can you try sharing the slides again? Can you see it? Can you share again slides, please?
Apologies to the audience. We have some glitches in the network, so we'll be with you shortly. Thank you for your patience. It's a shame. It was such a wonderful topic that Dr. Hawi is discussing, and we will be, hopefully, he'll be joining us soon. But meanwhile, maybe if, yeah, I think he's here now. So.
Hello?
Dr. Lawi?
Yeah.
Yeah, we can hear you. You can share your screen again. We can hear you.
Sorry, I'm sorry.
No, it's something wrong with the network. You're okay. Yeah, there you go. Put it on PowerPoint, please.
Can you see it now? Can you see it start now?
Yes, perfect. Thank you. Yes, please. Go ahead.
Again, we said sorry for the disconnection. Living with migraine can impact the family planning choice. And then we said 17% reported difficulty in their love life, and by 7% reported marital separation or divorce, and 1% reported having fewer children. We talk about this one. And then the main indication for preventive treatment is to remove the burden of migraine on patient life. Is the main indication. To answer that question, what are the indications for preventive treatment? Why we need new preventive treatment? It's a good question. Why we need, and I think we have, this man, he asked question, I think we have enough current oral drugs are quite enough. Why we need more preventive treatment? To answer this question, I say it was found that adherence to oral migraine preventive treatment can be poor because for some reasons, 85% of people with migraine discontinue oral preventive treatment within 1 year of starting the treatment. And this one showed the degree of how people they discontinue taking antidepressant, anticonvulsant, beta blocker, all of them. By time they stop reusing this drug and they discontinue, and this might be the main reason why we need to have new medications. And the side effects of medications and the contraindications. For example, beta blockers, they can cause hypotension, bradycardia, tiredness, fatigue, peripheral vascular disease, and they're contraindicating bronchial asthma, peripheral vascular disease, and diabetes. Again, antidepressants, they're good antidepressants because they elevate the mood in patients with migraine, but they cause drowsiness, dry mouth, weight gain, and arrhythmias. And just bear in mind that most of the migraine patients are young females and working years of their life. So they don't like to be drowsy with dry mouth and arrhythmias, and can cause of contraindication overweight and arrhythmias. Antibiotic medications are good. We use these medications, and they can cause benzodiazepines, fog of brain, weight loss or weight gain, tremor, hair loss, and peripheral neuropathy and kidney stone. These are contraindications. So this is enough to push people to look for alternative treatment for the prevention of migraine. If this lady is one of my patients, asked me 30 years ago, doctor, I fed up with these beta blockers, anti-epileptic, antidepressant, misalsergide. They have side effects. Their effect on migraine is not as good as they should be, and I don't like them. Is there any other options? Is there any other new options? 30 years ago, our sales patient, no, I'm very, very sorry. We don't have options. So we have to increase the dose of this one, reduce the dose, add that one, withdraw that one. That's the way we treat a migraine. Why I said 30 years ago? Because that's the time where I start doing my neurology training. So at that time, we don't have any medication for migraine apart from these listed drugs. If the same patient asked me 5 years ago, same questions, doctor, if I fed up with these drugs, is there any more? Is there any new drugs? I'll be very happy to say, yes, good news. We have new drugs. We have new drugs to replace these old medications. Although they're very good, they did very well for a long time, but we don't like patients to have side effects at the productive time of their years, of their life, productive years of their life. So the new medications are injectable, subcutaneous injection, erinumab and galcanezumab. These are safe and effective. I've got too many patients taking them, but they have a little bit of drawbacks. That means they are not effective in some patients. Some patients, they finish 9 injections, 12 injections without good response. And we have some patients they don't like to have the needle. And some patients prefer having long time between the injection because they can't come every month to have the injection. These are some of the drawbacks of this injectable subcutaneous injection. Since the introduction of the new medication for migraine, we have this terminology. You have episodic or chronic. Before I said migraine with aura, migraine without aura. And we have burden of migraine, quality of life, CGRP, calcitonin gene-related peptide. And we have MMD, monthly migraine days. And we have MRR, that means migraine responder rate. And we have MIDAS, migraine disability assessment scale. And we have RWE, real world evidence. You're going to hear about this in any of the migraine conference or meeting or discussion or symposium, or the one discussing the effective or the efficacy of any of the drugs, you're going to hear this terminology. طيب, is there any guideline for the use of new medication, new instead of the traditional drugs? Yes. According to the European Federation of Headache, we have this. They said that in individuals with migraine who require preventive treatment, we suggest monoclonal antibodies targeting the CGRP pathway to be included as the first line of treatment option. These are European guidelines. And then, is there any very long preventive treatment? We talk about the long preventive, talk about the short acting, long, and is there any very long? Oh, yes, there is very long. That is what we call eptizumab. Eptizumab is the first intravenous administered anti-CGRP antibodies. It was given intravenously, delivered in 30 minutes. The dose is 100%, with 100% bioavailability, and has rapid attainment of the maximum plasma concentration by the end of the IV administration. Immediately, that means high binding affinity, slow dissociation of the apitegromab, that these things will allow apitegromab to be delivered every 12 months. For the mean terminal elimination half-life is 27 days compared to the injectable drugs. Okay, and apitegromab is designed for immediate drug delivery and sustained duration of action. So it's selective binding, that means it's designed for no off-target affinity, strong binding, designed for sustained duration of action, and immediate availability post-infusion, and this make it designed for onset of activity within 24 hours, and with 100% bioavailability. These are features of apitegromab. It also does not work from day one after infusion compared to baseline. If you see this in this diagram, again, from day one, apitegromab start to reduce the severity, frequency of the attacks in both doses, in 100 doses or 300 doses. It will reduce the severity and frequency of the attacks. And again, it start working immediately after day one. It doesn't need 1 week or a few weeks to start working. It is approved in States and here in United Arab Emirates and in Kuwait and other countries as well. So it's used to prevent migraine in adults. Dose titration, the recommended dose is 100. There is no dose titration for every 12 weeks. Some patients may benefit from a dose of 300 if they do not respond to 100, but most of the patients are responding to 100. Sometimes we give 300 for some patients. Okay. It has some features, 100% bioavailability following IV administration, and bioavailability of subcutaneous injections, eremab and girmab, is 50% to 82%. This is 100%. And Cmax is 30 minutes compared to other is 5 to 7 days. So these are good features of apitegromab compared to the other subcutaneous injection. The delivery study showed significant and robust efficacy on the primary endpoint, reduction of MMD, monthly migraine days. So apitegromab proved to reduce the monthly migraine days in both chronic and episodic migraine by a significant number, and maybe up to 57 to 25%. So 50% migraine responder rate is high rate. So most of the patients that respond to the treatment in different doses, 300 or 100 compared to placebo. So the placebo, and this is the migraine in reduction of the, and responding to treatment of apitegromab. Also in episodic as well, and 1/3 of patients with apitegromab experience at least 75% fewer migraine days within the first month. So within the first month of treatment, it was for 3 months. There is significant more apitegromab-treated patients achieve 75% reduction in their monthly headache days compared to placebo. Again, 75% migraine responder rate is clinically meaningful measure that treatment success in patients with episodic and chronic migraine. This again proves that patients, they respond up to 75%. That's a high rate. In patients achieving more than 50% MRR to preventive treatment, there is the rationale for optimizing treatment and aiming for 75%. So this is the benefit of this drug, that it reduces or 75% of patients that respond to treatment with a high responder rate. Again, this comparing the 3 drugs we are using here, we use apitegromab, eremab, and galcanezumab. We don't use the others here locally here. So there's a comparison of the responder rate of the 3 drugs. See, apitegromab is high responding rate compared to the eremab and the galcanezumab, which are given subcutaneously, and apitegromab is given intravenously. Apitegromab reduces the likelihood of migraine attack on day 1 post administration. So if the patient found to have headache on the same day of infusion, the headache will improve immediately on the same day of infusion. And this reduction in percentage of patients with migraine by 50% after infusion versus average daily percentage during the baseline period. So it was found that on the same day of infusion, the eptizumab will start to reduce the headache up to 50% after infusion. How does eptizumab start working? Or how soon does eptizumab start working? This is a good question. So I took this from this paper by Mr. Dr. Study. He demonstrates that eptizumab efficacy within 2 hours when initiated during migraine attacks. If a patient is supposed to have a migraine and he has the infusion on the same day, the headache will start to improve immediately, and within 2 hours, the headache will be free. So this is the time of infusion, and after 2 hours, the headache will improve up to 50% of cases. Okay, so I asked this one of my patients. She came to hospital. When I saw her, she had severe headache, and I sent her for eptizumab infusion on the same day of the headache. How is your headache after the infusion? I phoned her in the afternoon after she had the infusion, and she said to me, "Doctor, I left the headache in your hospital." So that means the headache improved, and she left the hospital without any headache, and she left her headache behind. How long will the efficacy of eptizumab last? Oh, it's the longest of the anti-CGRP. We said the longest is the eptizumab, and less long is erlotinib and galcanezumab, and less long is the oral, all oral. So the early onset of eptizumab effect could improve the adherence to the treatment because patients found it very effective and it works straight ahead from the first day of the infusion, and that's why they come to the repeated infusion. So the rapid action and the sustained. The good thing that the drug will work for up to 84 or 5 days, and in some patients more than 90 days. It was reported some patients, and they come after 95 days, 96 days, and they are free of attacks. But most of the patients, they finish just 5 or 6 days before the end of the 3 months. And that will improve the adherence. The patients will like to continue the same drugs. Reduction in MMD, migraine monthly days, will push the patient to stay in the sustained the improvement of the headache will push the patient to stay in the drug, taking the drug. This for chronic and episodic migraine. And near the final slides, more than 80% of patients treated with eptizumab reported clinically meaningful reduction in MIDAS. MIDAS means Migraine Disability Assessment score over 2 years. So if some patient taken the drug for more than 2 years, here in our hospital, we have I think the longest patient now is 18 months. And we have patients starting in May 2022. So May 2023. So this is a sustained improvement of the disability or comorbidities or associated symptom with the migraine sustained throughout the 2 years. So it will never come down the scale. And 2/3 of patients with severe disability treated with eptizumab reported that migraine no longer has severe impact on their life. And we said this is the main indication for preventive treatment. So if you achieve that, 2/3 of patients taking the drug, they reported that the migraine no longer bothering them, and no longer causing any negative impact on their life. So if you look at this graph here, for example, this is mild disability. The severe disability is coming down on us. They get better with the treatment. Okay, it was proved to be safe. There is a review of 5 large-scale studies analyzed, and erlotinib proved to be safe and easily tolerated by patients over 2 years of treatment with very mild minimal side effects. There's no major adverse effect. These are the very mild, very, very mild dizziness, thermal hypotension, 1 in 20 patients. So in adult with chronic migraine with eptinezumab, 30 milligram administered IV every 12 weeks for up to 84 days as a preventive treatment demonstrate is a good safety and good tolerability of the drug because there is no major side effects and there is no major adverse effect were reported. 3 and 4 patients discontinued their initial oral. We mentioned that before because of side effects and because they can't tolerate it. And the speed of action of the drug, or preventive drug, is considered one of the most important factors that as a patient want to prevent treatment for. And to commonly prescribe oral preventive treatment, oral treatment, it needs some time to work, up to 6 months to start working fully. And up to 48% of the premature discontinuation of oral preventive treatment has been attributed to lack of efficacy. So that's one of the reasons why they don't take. Some people may accept the side effects, drowsiness, dry mouth, but they need the drug to work. If they're not working, they don't tolerate it with the side effects and not working. 30 minutes IV treatment every 3 months, no monitoring during the treatment, and the recommended dose is 100 milligram by infusion over 30 minutes, and this will give you a relief of pain for up to 3 months. No loading dose is required for Vyepti or for eptizumab. Okay, this is one of the last slides. Real world evidence showed that more 70 or 75, more than 75 reduction in MMD, monthly migraine days, in patients with chronic migraine with anti-CGRP antibodies. This comparing the good headed to comparing the eptizumab with erenumab and with galcanezumab. These are 3 we're using here. So look, if eptizumab is up to 60% here, this 45 and this 39, 37.8. So eptizumab on the top in reducing the monthly migraine days. Okay, so almost all the studies confirm that eptizumab is safe, no major adverse effects, immediate effect after infusion, maybe on the same day, sustained effect for 85 days, and reduced MMD by up to 75%, and sustained adherence to the drug from patients. So 120 minutes of hospital in capture means 365 days of freedom of migraine and associated symptoms. So it's worth to sit in the hospital for 120 minutes per year to have the whole year free of migraine and related symptoms. I don't think we have a time to go through this. Do you have a time to go through these cases, Roya?
Yeah, how long is this? I mean, we can do another few minutes if
I will do one case.
I think
Yeah,
why
and then
yeah,
conclude.
let's do one case.
This is a 6-year-old lady diagnosed with migraine without aura. She gets episodic migraine, frequent, that means highly episodic migraine. She works through her headache, a headache pattern and impact of, she gets 4 migraine attacks per month, 8 migraine days per month, and function well between the attacks, incapacitated during the attacks. So it got negative effect during the attacks, and feels tired after each attack. Always worried about the next attack. This most of the headache patient, when they finish attack, they're worried about the next attack. That's why they live in anxiety, as Dr. Hamid mentioned. They live in anxiety and waiting for the bad moment for the next coming attack. They should feel happy because they left one attack behind, but they feel worried about the coming one. Treatment, adjusted lifestyle, try 2 preventive medications with side effects and only minimal benefit. Never tried CGRP antibodies target prevention. Acute treatment unavailable. So searching for a reliable way to reduce migraine. So she's a good candidate for infusion, eptizumab infusion, started infusion. The headache pattern 3 months later after the infusion, from 4 attacks, they're down to 1 attack per month, and from 8 migraine days per month to 1, which is more than nearly 100%. Acute medication works each time. Acute medication, that means the tablet is taken for the acute attacks because there's already the eptilozumab in her system for 3 months. Second infusion, month without migraine attacks, so that complete improvement, and does not think about migraine anymore, which is a good achievement for this young lady. The second one is just a 37 years old man diagnosed migraine without aura and chronic migraine, works through her headache, 15 migraines attack per month, 22 migraines attack per month, sorry, and does most activities, but is less effective and just makes do. Feels ineffective as a wife and a mother, which is bad, and tried diet change and stress reduction, tried an antibiotic medication to prevent without benefit. I tried blood pressure medication without benefit, rarely uses acute treatment because it doesn't really help. So looking for options, which is a good candidate for the infusion, and headache after 3 months, from 15 attack to 6, from 22 days to 6 days per month, reduce intensity of migraine, willing to use acute medication that works. And 6 months later, about 3 migraine days per month and 3 days of acute medication period. So marked improvement in her migraine attacks. So just to conclude, let me skip this one. Conclusion, eptizumab is intentionally developed for IV administration to address patient needs. 1/3 of eptizumab treated patients experience at least 75% fewer migraine days within the first month. Eptizumab start working from day one, and this we see it in clinical practice. We see it in front of our eyes. After IV infusion, in patients with episodic migraine and in patients with chronic migraine, eptizumab demonstrated efficacy within 2 hours when initiated during a migraine attack. If a patient has got migraine attack, that day the headache will get better with infusion. More than 80% of patients treated with eptizumab reported clinically meaningful reduction in migraine disability scale and total score over 2 years. Eptizumab is generally well tolerated, with less than 2% of patients discontinuing treatment due to side effects. We have no discontinuation in our group of patients that have taken the drug, and they are happy and satisfied. قولوا قولي هذا واستغفر الله العظيم لي ولكم. Thank you very much, and sorry for the interruption during the talk.
Not at all. It was so wonderful. And it was really informative and learned a lot from it. Thank you so much to both the speakers. And I will now open the question and answers that are in the chat box. So Hind Moata is asking, Dr. Muhammad, it seems like now we are in an era of personalized migraine treatment. And she's asking, what historical lessons in migraine treatment can guide us in adopting emerging therapies effectively today? So I believe she's asking, we have learned a lot. Yeah, so she's saying, what historical lessons in migraine treatment can guide us in adopting emerging therapy? So is there anything we learned from the past as we've been treating and the new emerging therapies are helping us? So I believe
I couldn't
it probably...
understand the question. What is the emerging?
So it's asking...
What is the question? Sorry, right?
Are there any historical lessons that we have learned from the previous treatments that instead we are now using these new treatments? So what have we learned?
What I should say, because we don't understand the pathophysiology of the disease yet. But what we learned that the previous treatment, they have side effects. And I feel sorry for people who've been taking this drug for a long time with many, many side effects. The lesson is now we should not go to the back. We should go forward. and we should seek for more medicine that has no side effects or less side effects compared to the previous one. For example, methylphenidate, it causes for some patients severe retroperitoneal fibrosis, and some of them they end in renal failure and dialysis. So using medication like this one to stop the migraine or to prevent the migraine is not fair to have serious side effects. And all the other medication, oral medication, they have cosmetic side effects as well. So, and they're contraindicated in some condition in females. So now we learn that the new medication,
well said.
and I think we are a step, and I'm very pleased that I'm practicing to attend this new era of migraine treatment so that we can help our patients with the new medication without side effects or fewer side effects.
Yeah, perfectly said. We probably have 18-year-old son, and they're asking what is the most appropriate treatment for this age group. So I know that these medications are not approved for below 18 years of age, but in your practice, do you give these medicines to younger population?
Yes,
Dr.
I have
Mohammed?
two patients. I have two patients, 16 and 17. The 16 years old has got bad headache since he was 7. And he carried over the headache till being 18. And he came to my clinic. He's a very good 16. And I said, I'll try. His parents are very, very happy that from the first injection of one of the anti-CGRP, the headache recovered. He's now 17, but I started the medication. I know he's not licensed for 16 years old, but I said, okay, his body size is like an adult, and he's been suffering a lot. So better to try a drug without side effects rather than to continue the same medication. The second one is 17. So the cut age here in here is 16, and in UK, for example, is 18. So I gave him the drug, and the both of them are very happy. So I treat every patient differently on its own merit. So I can take a decision. Yes, I'll give the TNE agent. Yes, because it's safe drug.
Yeah, I agree that. Yeah, there is a trial going on, I think, on one of the CRGP, at least in younger population, and it depends if it's a good adult-looking, youngster, then maybe we can do it.
Yeah.
So I will now ask a question from Dr. Hamid, if he is still around. So Dr. Hamid, if you're around, there is a question regarding how can we address these? And also a question that you mentioned that some antidepressants can trigger mania in bipolar. Could you guide us which of those antidepressants do that?
So I only heard the second question, which I will answer, but if you could repeat the first one. So the second question regarding antidepressants
Go ahead.
bipolar disorder. This is an area of great concern that some antidepressants might trigger mania. And we are particularly talking about older antidepressants like tricyclic antidepressants. And that's why I mentioned in the treatment of migraine, some people might use older antidepressants, amitriptyline and so on, as mentioned by Dr. Muhammad. And these medications may trigger mania, so worsen the mood in patients who have bipolar. The newer antidepressants are less likely to trigger mania. Of course, the idea is that any antidepressant can trigger mania if it's not very well managed. If we know that someone has established diagnosis of bipolar, in that case, we need to have them prescribed a mood stabilizer. And we have a number of mood stabilizers that we can use. It can be a second generation antipsychotic, and it also can be some of the anti-epileptics that can be used, can be lithium. But the idea or the take-home message is that if you know that there is someone who has bipolar, do not prescribe them tricyclic antidepressants. And if you are to prescribe any other antidepressant, be cautious.
Right. Thank you for that wisdom. So the first question was, as we know that these medications are quite expensive, and I believe someone is asking, what is the most significant barrier patients with psychiatric conditions can address these? So I would like your opinion on that, please.
Yeah. So in terms of expenses, I think I like the idea that people make judgments about how they spend their money. So, those conditions, migraine, and particularly if there are psychiatric comorbidities, they come with a huge toll on the person's effectiveness and on how much they can manage day-to-day activities. It's actually, if we think about depression and migraine, indeed, both conditions are among the most conditions as per the WHO in terms of disability and impact on the daily functioning of any individual. So I think it might be false economy to avoid treatment for those conditions because you're far less likely to achieve your potential, if you're either not performing well in your job to get the promotion, or you're kind of constantly worrying about being kicked out because of, days of sick leave, or, maybe you're unable to find the right job for yourself because of how much you're disabled by these conditions. Then I think it would be money well spent to get the right treatment. But of course, if one treatment is not affordable, then you can think about, the alternative. I think getting the treatment is key. Getting the most effective treatment, the most tolerated, well-tolerated treatment is the ideal.
Absolutely. Thank you for that. Someone is asking, I think I will ask Dr. Muhammad kidney and liver, and they're asking if there's any connection or association.
Sorry, I couldn't hear most of the question. What? Sorry,
Yeah,
the line.
So is there any connection or association between CGRP and polycystic kidney and liver?
As far as I know, no. There is connection between sodium valproate and polycystic kidney, connection between topiramate and kidney stone. But as far as I know, anti-CGRP so far they are fine, and no side effects was reported. There was a study from Erenumab for the last 5 years in States, and there is no major side effects reported at all. But as you know, the sodium valproate can affect the liver, and the topiramate can affect the kidney. But I don't think there is the new medications so far. Hopefully, they don't have any major side effects in the liver or the kidney.
I agree. I haven't come across this either. Now, someone is asking, I mean, we haven't discussed pregnancy. So maybe Dr. Muhammad, yourself, and maybe also Dr. Hamid, yourself, if you could tell us about migraine and pregnancy and depression and anxiety related, as well as Dr. Muhammad, if these drugs are or can be taken and what are the washout. So I will ask Dr. Muhammad first to answer the first part of the question about pregnancy and these drugs and any washout that's necessary.
Okay, number one, migraine usually improve during pregnancy. And the patient may have severe attacks after delivery, like MS, for example. Number two, the old medications, they are contraindicated during pregnancy, all of them. Beta blockers, topiramate, and amitriptyline. The one you use for patients with severe attacks during pregnancy is amitriptyline. When we come to the new drugs, so far we haven't got enough number of patients to say yes, it is safe 100%. But I'm pretty sure in the very near future, that will come out that it is safe during pregnancy. Now we are collecting to register patients who have been pregnant while taking the drug. Myself, I've got 3 patients. They got pregnant while they having the injection, and they came very well to the clinic. I just say, just stop the injection, and they deliver 3 normal babies, so without any problems. So for the time being, the drug is labeled as contraindicated during pregnancy or breastfeeding, and should not be used during pregnancy and breastfeeding. If a lady she's planning to have pregnancy, we would be advised to complete her family first and then come to the medication. And by the way, I've got 2 of my patients, they stopped breastfeeding because they have bad headaches, so they're keen to take the injection. And waiting time washout for the drug, we will say it might be 3 months,
Right.
3 months to 3 to 4 months. Might be 1 month for the new oral medication for the prevention of migraine before pregnancy. But so far, we don't have enough data to say the drug is not safe or safe during pregnancy. But I believe it's going to be safe because no major side effects were mentioned.
Yeah, I think it's still early, and I think same goes for the breastfeeding. So, Dr. Hamid, what do you think how we can manage, depression with pregnancy is not uncommon, and then migraine. So, is there anything you would suggest as part of dealing with the comorbidity side of the migraine during pregnancy?
Yeah, I think it's important to have a holistic approach to treating depression and migraine in pregnancy. Pregnancy is an exciting time, and the expectation that everybody is happy, and congratulating the woman when she's pregnant. But let's not forget that not all pregnancies are wanted, and let's not forget that particularly depression can worsen the person's view of her pregnancy. We know that depression is more likely to happen in the perinatal period, so particularly a couple of weeks after the birth of the child. But because depression is such a common condition, it can happen during pregnancy at any time. We have medications that are generally safe in pregnancy. Some SSRIs, such as sertraline and fluoxetine, they have good evidence of being safe. Some older antidepressants, such as amitriptyline, they have the advantage of helping both kind of depression and also in migraine. I don't necessarily, if someone doesn't have depression, I wouldn't prescribe a higher dose of amitriptyline simply for the migraine, because migraine usually needs a lower dose of amitriptyline. But as I said, other SSRIs are effective and are generally safe in pregnancy. There is no 100% safe drug in pregnancy. We know even women who don't take any medication, they are at certain risk of either anomaly or getting harm to the unborn child. But as I said, some antidepressants are safe, but particularly after giving birth is a vulnerable period where treatment with an antidepressant, if there are any signs of depression, is indicated, and it should be really considered in addition to the other types of approaches like cognitive behavioral therapy, like relaxation techniques, like other self-help, sleep hygiene, and so on.
Yeah, thank you. That's really informative. So I think we are coming nearly to the end of the session, but I would just like to ask, in terms of young people, I mean, the school-going children, it's very difficult to identify what is migraine, what is not migraine, and what is, maybe other depressive or anxiety issue. So, Dr. Hamid, how would you suggest that they should see an expert and identify these factors, and rather than just ignoring them? Because as you know, that young children nowadays, they are learning a lot more, they're more open to information. So what advice you would give to people with young children and their headaches? Both for questions for both Maya speakers. So what, Dr. Hamid, what would you say?
Yeah. So first, I think we know that the way depression and anxiety present in younger people can be different. So they may not necessarily present with constant low mood and anhedonia, but it can be more of irritability, and it can be interpreted by parents or particularly by teachers and peers that this person is not nice to be with, because if you have psychological distress, you're not the nicest to yourself to be nice to other people. So I think having a thorough assessment of the individual, the child, depending what age they are, from a professional, a mental health professional, can help to identify symptoms of anxiety and depression and treat them effectively. Let's not forget that conditions like depression and anxiety are amongst the most effectively treated and managed with medications, but also with therapy approaches. So the advantage of getting that assessed and treated is great. Of course, if there are signs and symptoms of migraine, then I think it's best to be managed by a neurologist who's the expert in the field. And I would like to hand it over here to Dr. Muhammad to answer that.
Thank you, Dr. Hamid. Dr. Muhammad, you have any last thoughts? I think Dr. Muhammad's connection is not so good. And I would agree that it is a job for a specialist to identify the type of headache and so on. So I will just end this session. I think we are coming to the end, and I'd like to thank my esteemed speakers, Dr. Hamid and Dr. Muhammad Al-Lahawi, as well as the sponsor, Lundbeck, and the organizing committee. I would just summarize and say that we are in an era of wonderful migraine management, which is both trendy. I mean, how cool is it to say, I just had an injection or just had an infusion for my migraine and I'm free now. I can travel and not worry about my migraines. And I don't have to pop pills every day, and it doesn't give me any side effects. So that is pretty cool. And we are blessed to have these sort of treatments available to our patients who, as we all know as physicians, you see a patient who comes back and forth with the same problem, and we keep, messing around with medicines and we can't really help them. But now we are blessed that we can. So I think, Dr. Lawi, are you back? Can you hear me? Would you like to say the last few words?
So that's better. Yes, now I can
Yeah.
hear you. I don't know what's wrong with the line. So the last question
Yeah.
was
We're
the
just
use
saying
of.
last thoughts. Yeah, go on, please.
So what the question? The last using of treatment in young people or what?
Yeah, so if some people, it's very difficult to distinguish between migraine and attention headache and anxiety in young people. And what would your thoughts be on that?
That is one of the main challenges I just mentioned at the beginning of the lecture that faces in the clinic. When you have a patient with a young patient with, we don't know whether it's anxiety, we don't know whether it's real migraine, whether it's cluster headache, whether it is tension headache, whether it is muscular headache, whether it is because of he spent most of the night doing using these devices. So this is one of the problem, and we don't have a scale to measure the scale of we don't have a scale to measure the severity of the pain. And as I mentioned, investigation is normal, clinical examination is normal. I rely on the history. I'll take more history. If I stuck, I will go for what they call a therapeutic trial. I'll give him, for example, medication for migraine for 3 months and advise him just change of lifestyle, avoid the stress, lack of sleep, plenty of water, avoid spending a long time with the screens, and this sort of advice. And then I'll see him after 2 months, 3 months, see how he's getting on. If there is improvement in the headache frequency, severity, the patient is happy, I will continue I will take it as migraine. And if not, I will seek the advice of my psychiatrist. We used to have a neuropsychiatrist by side every week, neuropsychiatric clinic, together with the psychiatrist to discuss these cases. But too many patients, they have the same problem. Even our patient who is known to have migraine, they may come with a symptom of anxiety and depression and insomnia as well. So most of them, they're taking the anti-CGRP plus one of the tablets to improve their sleep as well. But what I noticed that in clinical practice, when we have got a study of 340 patients taking the anti-CGRP, what you notice that when you improve the headache, the other symptoms improve as well. We have patients
Yes.
cervical radiculopathy, the pain improve, trigeminal neuralgia improve with the headache improve, and patients had got gastric surgery, bypass surgery, and so got diarrhea, and that improve after with the medication as well. So it has not only the effect on the pain, but I think on the general well-being of patient with a migraine. So I agree with you. This is patient forming a lot of channels for us in the clinic when we're faced with patients with, we don't know whether it is anxiety secondary to migraine or the headache is secondary to anxiety.
Indeed.
So you have to sort out every patient by itself.
Thank you so much, Dr. Mohammed, and once again, Dr. Hamid Al-Hajj, and I thank the organizing committee and IVPN Neuropsychiatry organizers as well. So I think we will call it end of the session. We're at 10 o'clock, and I wish you all good night, and thank you for attending, and thank you to all the audience. Thank you.